The section on antithrombotic medication, this is very important, and in patients with symptomatic peripheral arterial disease, single antiplatelet therapy is recommended to reduce the risk of major adverse cardiovascular event. This is a class 1 recommendation. This can be done with aspirin or clopidogrel. In patients with asymptomatic peripheral arterial disease and in patients who have undergoing endovascular or surgical revascularization, low-dose rivaroxaban 2.5 mg BD combined with low-dose aspirin is recommended to reduce the risk of major adverse cardiovascular event and major adverse limb events. Symptomatic peripheral arterial disease, single antiplatelet therapy, and patients who are undergoing revascularization procedure, either endovascular or surgical, combination of aspirin and low-dose rivaroxaban. These two are class 1 recommendation. Let's talk about concomitant medications. Can these patients benefit from anticoagulation? Can these patients benefit from lipid-lowering therapies? So the guideline states that patients with peripheral arterial disease who do not have a compelling indication, for example, atrial fibrillation, mechanical heart valves, rheumatic heart disease with mitral stenosis, should not receive full intensity oral anticoagulation to reduce the risk of major adverse cardiovascular or limb events. In the previous section, we discussed that these patients can benefit from low-dose rivaroxaban in combination with low-dose aspirin, but full intensity oral anticoagulants require a compelling indication. So this section clearly states that these medications in full doses should be avoided routinely. And in patients with peripheral arterial disease, treatment with high intensity statin therapy with an aim of achieving a more than 50% reduction in LDL cholesterol is recommended. This is a class 1 recommendation. And if the goal is not achieved with the high intensity or maximally tolerated statin therapy, and the patient still has an LDL cholesterol values of 70 milligram per deciliter or more, it is reasonable to aid PCSK9 inhibitor therapy and or ezetimibe, and this is a class 2A recommendation. So to sum up, anticoagulation in full doses should be avoided in the absence of compelling indications, and patients should receive initially high intensity statin therapies, and if the goal LDL is not achieved with the high intensity statin therapies, these patients should in turn be started on additional lipid-lowering therapies like PCSK9 inhibitors and or ezetimibe. In patients with peripheral arterial disease and hypertension, antihypertensive therapy should be administered to reduce the risk of major adverse cardiovascular event, and the aim should be a systolic blood pressure of less than 130 millimeter of mercury and a diastolic blood pressure of less than 80 millimeter of mercury. Every eligible patient should receive antihypertensive therapy, and the goal of antihypertensive therapy is to reduce blood pressure below 130 systolic and 80 millimeter of mercury diastolic. Selective use of angiotensin converting enzyme inhibitors or angiotensin receptor blocker is recommended to reduce major adverse cardiovascular events. These patients should receive guidelines directed therapy to reduce their blood pressure, and the best choice is to use either ACE inhibitors or ARBs for these patients to reduce major adverse cardiovascular events. Continuing with medications, in particular for patients with type 2 diabetes, the use of drugs which improve major adverse cardiovascular events, for example, glucagon-like peptides and SGLT2 inhibitors are recommended, and they are effective to reduce the risk of major adverse cardiovascular events. And in patients with claudication, cilostazol is recommended to improve leg symptoms and increase walking distance. However, cilostazol should not be administered in patients with congestive heart failure of any severity, and pentoxifylline and chelation therapy are not recommended for the treatment of claudication. Avoid these unnecessary drugs.